Gastric outlet obstruction is the third most common complication of peptic ulcer disease. In the past it was affecting 5 to 12% of the patients, but nowadays it is becoming rare due to the effective medication. Most often it affects the duodenum due to its narrow lumen compared to the stomach, and although it represents a benign condition, it shares the same clinical picture with malignant obstruction. As a result, malignancy should be strictly ruled out in every patient, especially in the absence of a long-term history of peptic ulcer or in patients older than 55 years old. Initially the stomach compensates by increasing the strength of peristalsis, but as the situation progresses propulsion fails and the stomach ends up hanging, dilated, and loose. This is a slowly progressing procedure and the relevant clinical picture develops gradually. Stagnation of food in the stomach leads to early satiety with postprandial fullness and occasionally epigastric pain. Subsequently the patient loses appetite and decreases food intake, ending in loss of body weight. Gastric distension can also cause antiperistalsis and sudden vomiting of large quantities of undigested food. This typically does not contain bile, a characteristic symptom of the condition. In physical examination, the gastric peristalsis is sometimes visible, while succussion splash can be heard. This is the characteristic sound of stagnant gastric content when the patient's abdomen is shaken, as first described by Hippocrates. On a plain abdominal X-ray an air fluid level will be seen, and contrast studies will show a dilated stomach. The gastric outlet will not be patent. The contents may be arranged in 3 layers with air on the top, and gastric juice overlying the barium sediment. Peristalsis will be weak or intense, depending on chronicity. The same signs will be seen in CT scans, but in case of malignancy, signs of regional or systemic spread may also become evident. Upper gastrointestinal endoscopy allows the examination of the affected area, the pathological anatomical diagnosis, and the assessment of the degree of stenosis. Endoscopy of course requires emptying the stomach with a nasogastric tube. The test of gastric catheterization can also assist in the diagnosis. Drainage of more than 300 ml 4 hours after a meal, or more than 200 ml after fasting for 12 hours will set the diagnosis. Needless to say that there will be no bile in the drainage. Alternatively, the old test of gastric rapid filling with saline, in a patient with empty stomach can be of assistance. In this, we instill 750 ml of saline into the stomach in 5 minutes, close the nasogastric catheter for 30 minutes and then check the amount remaining in the stomach. In a healthy person this should be less than 200 ml, amounts between 200 and 400 ml are suspicious but not diagnostic, and more than 400 ml set the diagnosis. Continuous vomiting leads to loss of fluids and acid. These cause dehydration and hypochloremic hypokalemic alkalosis, which can be detected in serum biochemistry and acid-base balance. The loss of hydrogen cations and chlorine anions leads to alkalosis and hypochloremia. To compensate for alkalosis, the kidneys excrete increased amounts of bicarbonate in combination with sodium cations causing urine alkalization, and relative hyponatremia. This, in combination with negative fluid balance, stimulates secretion of aldosterone which in turn causes sodium retention, excretion mainly of hydrogen ions and acidification of the urine. The situation of passing acid in urine while the patient is in alkalosis, and in need of the wasted acid, is traditionally called paradoxical aciduria. Aciduria worsens alkalosis. To compensate, proteins release the hydrogen ions they are bound to, and exchange them with calcium ions. Thus, free plasma calcium decreases. Profound hypocalcemia might end into tetany, an additional life-threatening complication besides hypokalemia. The treatment consists simply of administering isotonic sodium chloride. In this manner, the chlorine and sodium deficits are replenished, allowing the excretion of alkaline urine, while fluid balance is restored. Local inflammation, for whatever reason, with subsequent tissue edema and muscle spasm, may add to an already existing deformity and transform a partial obstruction to complete. This is simply treated with nasogastric drainage, maintenance of fluid and acid-base balance, and anti-secretory treatment. These measures will resolve the acute setting, but evidence on its long-term outcome is lacking. Reasonably, further intervention will be required to definitively solve the peptic ulcer disease itself. On the other hand, chronic obstruction is due to tissue fibrosis and permanent gastric outlet deformity. In such a case, conservative treatment is likely to fail, so the aim is to eliminate or bypass the obstruction. Pneumatic dilatation of the gastric outlet stricture under endoscopic or radiologic guidance leads to immediate resolution. Diet with clear liquids can start immediately with rapid advancement after a few days. Most patients have no Helicobacter infection, but if needed, eradication should be performed on the same time. Complication of dilatation is rupture. This can be avoided if the balloon diameter is less than 15 millimeters. Early results are satisfactory, but in 30 to 70% of the cases recurrence will happen, needing re-intervention. Recurrence is the outcome of continuing hyperacidity. Even when dilatation is combined with parietal cell vagotomy, recurrence rates can reach 30%, and restenosis up to 16%. Restenosis can be dealt with redilatation or with surgery. If recurrence appears in less than 2 years, or if more than 2 dilatations are needed, failure of dilatation strategy should be expected. In these cases, surgery is indicated. Surgical elimination of the obstruction can be achieved with pyloroplasty as described by Heineke-Mikolits, or a duodenoplasty as described by Kennedy. The latter is a longitudinal incision and a transverse closure of the duodenum, similar to Heineke-Mikolits plasty. If both pylorus and duodenum are involved, Finney's-plasty is appropriate. Alternatively, the obstruction can be bypassed with Jabolas androduodenal anastomosis or a simple gastrojejunal anastomosis. Each operation has advantages and disadvantages. If there is extensive fibrosis, the duodenum is not amenable to manipulation for a quick plasty or an androduodenal anastomosis. Furthermore, Finney's-plasty or Jabolas anastomosis are characterized by increased rates of dumping syndrome. A simple gastrojejunal anastomosis offers the advantage of bypassing the deformed ulcer area, but there is always the risk of developing anastomotic ulcers. Each patient should undergo the operation that suits best to his condition. At the same time, a simultaneous permanent solution for the underlying peptic ulcer disease should be considered. This usually is a truncal or selective vagotomy. In the case of gastric ulcer, concomitant treatment of the ulcer itself requires vagotomy and antrectomy. It is characterized by mortality 2%, recurrence rates less than 1.5%, and dumping syndrome in 25%. This, however, is minimized in the long run. Unfortunately, truncal vagotomy and antrectomy is also accompanied by 23% diarrhea and 4% alkaline gastritis. For this reason, although this procedure can be performed on duodenal ulcers too, it is not the preferred one. Data comparing the various procedures are incomplete and outdated, but luckily, the incidence of gastric outlet obstruction due to peptic ulcer disease is minimal nowadays with the modern and very effective medication.